I'm Dr. Payne. I work out at THD mostly and at the VA some, and I'm going to be talking about traumatic nerve injuries today. It's kind of just a broad overview, really, but I know you guys have boards coming up, and so some things about grading, the types of repair and timing of repair might be useful for that. So we'll talk about a few different things. One, just broadly types of nerve injuries. So specifically things like the mechanism of injury. We'll talk about like lacerations or blunt injuries or stretch injuries, things like that. I will describe the different types of nerve injury grading and some of the different grading schemes and why that's important. And then we'll talk about the different treatments that we utilize when it comes to nerve repair or secondary repairs to deal with deficits related to traumatic nerve injuries. Briefly, we'll kind of review some of the anatomy and physiology, go over some of the histologic features of nerves and fascicles. We'll go over the epidemiology of nerve injuries, briefly pathophysiology and injury types and classifications, and then diagnosis and treatment. So when we think about the peripheral nervous system, this goes back to just basic anatomy in first year medical school, but we think of nerves and ganglia outside the brain and spinal cord. And this involves both the autonomic nervous system and also the somatic nervous system. And most of the time when we're dealing with nerve injuries, we're dealing with the somatic nervous system. And this is composed of spinal nerves and then come together in 4 different types of plexus in different areas of the body. So this could be the cervical plexus, or it could be the brachial plexus, or the lumbosacral plexus. We deal with injuries to all these areas, and then they, of course, go on to their target organ. Now, when we get into the grading schemes, it becomes really important to talk about the different layers of the nerve and the kind of these different histological features. So if you take a full nerve in cross section, then you have this picture on the left, and so it's a bundle of fascicles, and you have both external and internal epineurium, which separate these fascicles. The fascicles themselves are bound by perineurium, and then in between the axons inside the fascicle, there's endoneurium. So these are all different types of just connective tissue that bind these axons together into fascicles and ultimately into the actual nerve itself. And of course, that's the axon, that second picture. Now, on the top right, and these are all grace plates, so some of the wording that's used is kind of old, but on the right, top right side, you see axons and cross section. You see the axis cylinder where the electrical impulse is conducted, and then you see the medullary sheath, or the myelinated sheath, myelin sheath, and then the neurolemma, which is just the cytoplasm of that Schwann cell. And then if you look at a longitudinal cross section, you again see the axis cylinder, the insulation, basically, which is the myelin sheath, and these different nodes around VA. Now, I guess when I think of nerves and nerve injuries, I think about it like an electrical diagram. And so you see, when you look at these nerves that are in cross section, they resemble a bundle of wires, complete with insulation. And so as we kind of go through this talk, we're going to be thinking of nerves in that way, and especially when it comes to localizing the area of injury. I guess, before we kind of get into the specifics of nerve injuries, the question is, why is it important? Is it really something that we see all that often? And, I think that as kind of understanding of nerve injuries, as we look for them more often than we find them. But this is a paper by Susan McKinnon, who is probably one of the best known neurosurgeons in the world. And they just looked at a cohort of 1.2 million people who came into the emergency department with an extremity trauma. And they found that in 2.6% of upper extremity traumas and 1.2% of lower extremity traumas, there was also a nerve injury. It was usually a single nerve injury, and most of the time, it was not diagnosed in the emergency department. So, and about 38% were diagnosed by the time of discharge, but the remainder were not identified as nerve injuries until some point during follow-up. And these folks who had a upper extremity or lower extremity injury and a nerve injury went on to have a significantly higher incidence of chronic pain. They needed PTOT more often, and other things as well. So not only is not only are nerve injuries more prevalent probably than we think, they're not usually diagnosed in the immediate period around presentation to the hospital, and the disability associated with them is significant. And then this is just looking at the common causes of nerve injuries from that same paper. And you can see, the gray brachial plexus injury, and you can see that other than with fall, it's the most common. So things with motor vehicle accidents, motorcycle accidents, these are, commonly the things we think about when it comes to a brachial plexus injury. Now, I think probably with the fall, the reason the median and the ulnar nerve went out is probably because of fracture-associated injuries to the nerves. So again, when we talk about nerve injuries, we talk about a couple things. One is the mechanism of injury, and then the other one is the classification of the injury or the grading. And both are very important when it comes to the type of repair that needs to be done and the timing of repair. So broadly, you can have a sharp transection to the nerve. So a knife wound, broken glass, lacerating a nerve, a bone fragment, or iatrogenic wounds from surgery. The classic one we hear of is a lymph node biopsy kind of gone wrong, basically, and you end up cutting out the accessory nerve. You can also have like a blunt transection, and this is kind of from the literature with Klein, and they always mention something like a propeller injury. Now that's not something that we deal with here as much, but something where you have a tearing through the nerve, and so the nerve ends are not clean. They're not cleanly cut. They're kind of torn apart, and so the vesicular architecture on either side is really distorted. Gunshot wounds can do this too. Now, I'll say the vast majority of gunshot wounds do not result in nerve transection. Most of the time, it's a blunt injury to the nerve that results in something like a neuroma incontinuity or stretch injury. And then last, you can have blunt injuries, stretch injuries, blast injuries, and these all leave the nerve in continuity, but it distorts the internal architecture of the nerve. So you, in effect, have a nerve that is discontinuous, but when you look at it, say in the operating room, you'll see maybe a neuroma or an irregularity, but it's not transected. So in the peripheral nervous system, what happens when you have a nerve that's transected is that immediately the distal portion of the nerve will still conduct an impulse, which is really, really pretty interesting. And so if you get to an injury quick enough, you can actually stimulate the distal end and see when muscles it goes to, so that you can align the fascicles appropriately. But after a couple days, you'll start to see wall area degeneration, which means that distal axon or the axons in that distal nerve bundle start to degenerate, and so they end up, and then of course the muscle that goes to starts to die as well. So you get denervation atrophy. which is a death of these muscle cells that is irreversible, basically. It's different than just atrophy from, say, like a sedentary lifestyle or from not using the muscle. This atrophy results in permanent loss of muscle. As the nerve begins to repair itself, it'll send out these axon growth cones and axon sprouts. And so it'll endeavor to bridge whatever gap that there is and make its way down to the target organ. And as it does this, the Schwann cells will also proliferate and help bridge that gap as well. And eventually, hopefully, it'll make it down to the target organ. Now, of course, this is in a perfect situation, and maybe this is something that we see most often with something like a type 2 injury, which we'll go into, where the structure of the nerve is pretty well preserved, but it's just the axons that have been damaged. And so the axons don't have a difficult time making it back down to the target organ. Whereas you can imagine if the nerve is completely severed, it's going to have a very difficult time making it past that gap. Classically, there are a couple of very well-known grading schemes. These have been kind of added to over the years with different authors, but in general, these are the two. And again, treatment depends not only on the grade of injury, but also the mechanism, which we've talked about before. And so this is from the original paper published in 1942 by Dr. Seddon. And he broadly categorizes this into three groups. So there's neuropraxia, axonomesis, and neuromesis. The first one we're very familiar with. And neuropraxia itself is just a conduction block. The axon's intact, the endoneurium, perineurium, epineurium are all intact. But for whatever reason, there's a block. Now, sometimes that can be due to compression. It can also be due to demyelination of a segment. But basically, the impulse that's starting is not making it past this injured segment. The next one would be axonomesis, which is a disruption of the axons with preservation of the surrounding structures. So if you try to think back to that original diagram, with the nerve, with the multiple bundles, all of the supporting structures are intact, but the axon itself is disrupted. So unlike a neuropraxia, this actually means that the axon has to elongate past that level of injury. So there is Wallerian degeneration. So recovery from this takes a while. The thing that we quote people is, an inch a month or a millimeter a day. So if you have an injury to the nerve, say at the elbow, you can expect that it's going to take a very long time to see an improvement as time goes on, as the axon elongates back down to the target organ. And the last one is neuromesis, which just means a cutting, which is a complete disruption of the nerve. So that if you opened up and looked at the nerve is in two pieces, basically. And in this paper, he put in a nice table here, but really to just explain that it's impossible to treat all nerve injuries according to their mechanism only, because they can result in different grades of injuries. So what I mean to say is, if you look at this table, a direct blunt injury or a traction injury or open wounds, all of these things can cause a neuropraxia, disruption of an axon, or disruption of the entire nerve. And so the point of this paper was to say that it's not just about looking at the mechanism, it's also looking at the grading. And to quote him from this paper, it says, the diversity of etiology shows how fruitless it is to classify injuries to nerves according to the kind of violence inflicted, since the same injury may, in certain circumstances, produce different lesions. Perhaps the better known classification system, and one that we use more often now, is the Sunderland classification. And this really just kind of expounds upon the Seddon classification. And so, if you think about that neuropraxia or the conduction block, this in the Sunderland classification is a grade 1 injury. If there's disruption on the axon, which is like a Seddon, axonic mesis, this is a grade 2 injury in the Sunderland system. And as we go through, basically you add disruption of a supporting structure until you have disruption of the entire nerve itself. So a grade 3 injury would be disruption of the axon plus the endoneurium. A grade 4 injury would essentially be disruption of a fascicle because the perineurium is damaged as well as endoneurium and the axon. And then ultimately, grade 5 injury would be if the epineurium is also disrupted. So if we look at these, kind of compare the two classifications and look at the prognosis for each one, you can see it varies substantially. So as I mentioned before, a neuropraxia or a conduction block, something that we sometimes see with, stretch injuries or, stingers or, blunt injury to a nerve that at first there's weakness, but it gradually recovers. This most of the time recovers in less than 3 months. And there's no Wallerian degeneration. And if you were to get an EMG and nerve conduction study, what it would show is that conduction through the nerve may be impeded, but there would be no changes to the muscle or no denervation changes. So if you kind of think back to that picture of what happens when a nerve is injured, unlike with the other grades, you wouldn't see that the muscle starts to die because the nerve ultimately is still in continuity with its target organ. But you would see that there may be slowing of conduction, just no positive sharp waves or fibrillations, which are indicative of ongoing denervation atrophy when an axon is severed or a nerve is in discontinuity. The next one, which would be a grade 2 injury or the Seddon axonic mesis, this recovers about 1 millimeter a day. And again, recovery is really pretty good with these, but it takes a long time. And you will see denervation atrophy. The good news about this is that because the structure of the nerve is ultimately intact, that these axon sprouts are able to make it down to the target organ without as much loss of function as with these other types of injuries that require surgical intervention. Grade 3 injuries have variable recovery. It really depends on the type of injury and the patient. But grade 4 and grade 5 injuries, so ones where you either have a complete fascicle disrupted or the entire nerve disrupted, these do not recover. And these will not get better over time. And these require surgery. Now, the difficulty with this is trying to determine which people have grade 4 and 5 injuries and which ones have, grade 2 injuries. And so just to kind of drive that same point home, the treatment and timing of treatment are dependent not only on the mechanism of the injury, meaning is it a sharp laceration, is it a tearing injury, is it a stretch or a blunt injury, but also the degree of injury, which is the classification systems we just went through. So when we start to think about how is it that we're going to decide, first of all, how bad the injury is, and then how to repair it, we start with basic things: history, physical exam, and there are some things that will that will stand out that clue you in that there may be one type of injury over another. So I think the first thing that we look at, is this a penetrating injury? So is this a sharp injury resulting in immediate loss of function? Because if it is, then we can say that in general, that is going to be a grade 5 injury. Or a grade 4. There's going to be a disruption of the nerve or part of the nerve due to a sharp injury, and those should be repaired right away. Or is this a traction injury? So is this like a motorcycle accident, where the head goes one way, shoulder goes the other, and then you have weakness in a very specific distribution. So like with this would be commonly like an upper trunk palsy, because that has to be dealt with in a much different way. Are there other associated injuries, things like fractures, lacerations, hematomas? Certain types of fractures, long bone fractures specifically, are related to nerve injuries. The most common one would be, say, like a humerus fracture and a radial nerve injury, or a hematoma. So a hematoma in the psoas, for instance, can cause lower extremity weakness. Hematoma as a result of a shoulder dislocation can cause significant weakness. And these things should be intervened on sooner, because that's a reversible cause of injury. Is the neurological deficit, is it delayed, is it immediate? A delayed deficit goes along more with like an idiopathic neuritis or a Parsonage-Turner syndrome, which is something you don't want to operate on right away, if at all. Or is it immediate, which would fit more with the injury and the weakness going along one with another? Is a deficit improving? Is it worsening? And I think I've shown this slide before, but in general, when trying to discern between nerve injuries versus root injuries versus spinal cord injuries versus a brain injury, as you go more distally in the peripheral nervous system, you're going to see that, as you go more distally in the nervous system, you're going to find that the findings are more discrete. So, a hemispheric stroke is going to result in a whole lot of problems, whereas, say, a median nerve injury just at the wrist is going to result in a much more discrete findings. And then this slide is just to kind of demonstrate that same thing. You can see that with different types of dermatomes, there is extensive peripheral nerve overlap. So what I mean to say is multiple peripheral nerves comprise a single dermatome. Also with diagnosis, imaging becomes important. I've started to change kind of what I've done in the past, which is I used to always get MRIs, and now I probably do ultrasound more often because I can ultrasound along the entire course of the nerve, and then I can also do intraoperative ultrasounds and kind of correlate those findings. But MRIs are good at showing anatomy, and probably more beneficial than just showing the nerve injury itself is looking at the surrounding structures. So I see a lot of shoulder dislocations. I see a lot of people with foot drops after hip arthroplasties, things like this. And so it'll show the joints, it'll show the tendons, the muscles, and it'll also show if there's any denervation atrophy, because that'll show up bright on stir. It'll even show whether atrophy is chronic or acute, or it can also clue you into whether a patient might have something like a myositis. But the ultrasound is really nice because it can show notching of the nerve, it can show distortion of fascicular architecture, and it's really good at showing things like a neuroma in continuity or other nerve lesion, which is nice to know before surgery. And so electrodiagnostics, this is a a topic probably for a whole nother talk, because it gets quite complicated. But in general, EMGs and nerve conduction studies are not indicated right away. And the reason for this is if you do it too early and you test distal to the site of injury, you may still show conduction through the nerve. If you do it kind of subacute, but before 21 days, then you may not see the positive sharp waves and fibrillations that you need to see to indicate that this is a grade 2 injury or worse. And this kind of explains that Wallerian degeneration takes time to start, and denervation changes occur after several weeks. It is helpful when working to assess for a specific nerve lesion, especially with a brachial plexopathy, and also when looking to see if there is a good donor option. What I mean to say is, if the nerve is to be reconstructed using a nerve transfer, we want to make sure that the donor muscle groups, donor nerves, are healthy. And so if I'm going to do something like an accessory nerve to suprascapular nerve transfer, not only do I want to take a look at the supraspinatus and infraspinatus to make sure that there is no axonal continuity to those nerves, but I want to look at the trapezius, and I want to see that the muscle is healthy, which would be indicative of a healthy accessory nerve that I could swing in and reinnervate the supraspinatus and infraspinatus. It's also helpful to classify the severity of the lesion. So again, if you don't see denervation, that helps you think that, hey, maybe this is just a neuropraxia, that this will get better with time. And if you test for compound motor action potentials, meaning you stimulate the nerve and there is no response of the muscle, this tells us that the nerve is not in continuity. And so if the nerve is still not in continuity, if it has not made its way back down to the target organ within 6 to 9 months, then it's not going to help to wait any longer, and you may need to intervene in some of these stretch injuries or brachial plexopathies. And this is just to kind of drive home that point about the timing of EMG and nerve conduction study. So this is a video of a median nerve transection and brachial artery transection that we repaired. And you can see that the nerve is in 2 halves, but when you stimulate, you actually get response, a motor response. And this is because this was intervened on right away. So, to kind of try to kind of wrap things up a little bit, the treatment depends on the type of injury and the mechanism of injury. As we talked about before, grade 2 injuries will get better over time. Grade 3 sometimes get better. Grade 4 and 5 injuries never get better and will always need surgery. Now, of those that always need surgery, when do you do surgery? Well, a sharp injury, you have to repair as soon as possible. So a clean cut through the nerve, repair that as soon as possible. A blunt laceration or a tearing injury, you may need to wait some time. And the reason for that is because as time goes on, the ends of that nerve will die back and the fascicular architecture is distorted. And so you will have to cut back that nerve until you get to healthy fascicles before repairing it. If you were to suture together 2 ends of a very ratty nerve, there will be no recovery. And then a traction injury or a blunt injury, that's always going to be a delayed repair with grafting or nerve transfers. So what to do acute? Sharp transection, that should be repaired as soon as possible. The repair should be end-to-end if possible. If it cannot be done end-to-end, you can do an interpositional graft, like we see here. Things like hematomas causing nerve compression should be evacuated right away. And then in the case of a gunshot wound or a blast injury, it might be helpful to explore the wound, understanding that the nerve, even if it is transected, should not be repaired in that setting. But you can go in and tag the ends of the nerve so that when you come back, it's easier to find. What should be done delayed? So a tearing injury of the nerve should be done in a delayed fashion. And again, this is a Sutherland 5 injury, but the ends of the nerve have not been sharply cut. They're ratty. The fascicles will not look normal intraoperatively, and you will have to cut back that nerve until you have healthy fascicles before doing the definitive repair. So you should give it a few weeks basically before going in to do the definitive repair. Stretch injuries, brachial-plexopathies, things like this, you're going to have to wait a while. And the reason for waiting a while is that, again, to use that, use the same illustration, if you have an injury at the nerve at the elbow, it's going to be hard to tell whether that is a grade 2 injury where the axon is disrupted versus, say, a grade 4 injury where you may not be able to see that the nerve is in 2 pieces, but internally it's disrupted. Both nerves look to be in continuity. One will recover, one won't. How do you tell? And the way you tell is you follow over time and look for signs of recovery in the proximal muscle groups. And you also follow with electrodiagnostic studies to see if there is at some point, usually by 6 months or 9 months, depending on who you are, if there is a compound motor action potential. The treatment for these is always nerve transfer, meaning taking a healthy nerve and tying it into an unhealthy nerve. Nerve grafting, meaning cutting out the neuroma or the unhealthy segment and putting in a graft, or secondary measures like tendon transfers. These types of injuries require multiple people, multiple specialties. I would say that plastic surgery, orthopedic surgery are extremely important for a comprehensive approach and treatment of these injuries. So in conclusion, timing and type of treatment depends on the type of injury and the mechanism of injury. In general, sharp injuries should be repaired as soon as possible. Blunt transections should be delayed, and stretch injuries should be done months later. And then those will be repaired but through secondary means, not direct, nerve repair. That's what I have.
Thanks, Russell. That was really good and really on point. I think that your conclusion slide is probably enough to pass your peripheral nerve case if you got one on the boards, and it's boiled down to its essence. But the overall grading and management pops up on written boards all the time and is an important part of oral boards. And I hope you'll continue doing these peripheral nerve talks as we move through. I think it's really valuable. It's just something we don't see as often.
And one thing that's epidemiologically really interesting is with helmet loss, brachial plexus injuries significantly increase because people survive motorcycle accidents and now develop brachial plexus injuries. So when I was doing about 80% of my practice were motorcycles and brachial plexus. It happens more often.
Yeah, just mentioning that with increased survival with accidents that there's more of these injuries. Okay, thanks, Russell.